Welcome, everyone. I'm Steve Patterson, the Executive Director of MedVR. Welcome to another of the MedVR Talk series. This is the 49th talk we've hosted. All are all cover different fields within medicine. But are common in their theme in that they chronicle the journey of the medical XR innovator. MedVR is a nonprofit that educates about and precipitates research in medical XR. We have 7,500 interdisciplinary people around the globe who follow MedVR. You can support our work by donating through our website. Little note on housekeeping. You'll note at the bottom of your screen that there are two chats. One is a chat for the attendees, and the other chat is for submitting questions. It's called Q&A chat. Please keep your questions there. We don't have the next talk to announce. We're putting together a talk with the FDA based upon their recent summit. There are some important points to recap, and that'll be later on this month, and you'll see it on our website. I'm pleased to introduce our moderator, Dr. Jeffrey Jacobson. Jeffrey brings 30 years of experience in research, engineering, and applications of VR, AR, and XR technology, beginning during his doctoral studies at the University of Pittsburgh. He is the XR lead in immersive design systems at Boston Children's Hospital. Jeff is a cognitive engineer, expert on how people process information. He was one of the first researchers to use game technology for VR, and he's been cited over 1,500 times. So from there, let me turn things over to Jeffrey and look forward to this talk.
Excellent. Thank you, Steve. I'm happy to welcome Walter Jean. He is the chief of neurosurgery at Lehigh Valley Health Network. He's also a founder of the Global Brain Surgery Initiative. And he's a pioneer in the area of AR and VR for neurosurgery, and particularly in the skull, I believe you said, near the base of the skull. And he's done a really interesting study where he's got some solid results in the use of VR for surgical planning and mixed reality for guidance, assistance of surgery. So without further ado, I'll hand it over to you.
Thank you very much. I hope everybody can hear me, and I'm going to share my screen and my PowerPoint. All right, and let's go to the talk. Okay, so everybody can see my slides, I hope. All right, so thank you for this opportunity to speak in this forum. I'm going to talk to you about my use of the mixed reality system in our hospital for doing cranial surgery. And a lot of it is show and tell. Some of it is telling you about the study that we've done with regard to our first 100 cases. And I welcome your questions and your input and whatnot. This is who I am. I am at the Fleming Neuroscience Institute in Lehigh Valley. I'm also the professor of neurosurgery at USF. And here is Eastern Pennsylvania, Lehigh Valley for you. This is where we practice. And these are my disclosures. Surgical Theater is the VR, AR company that created the software that we use. So I don't have to tell this audience about VR. Specifically to neurosurgery, we take everyday black and white two-dimensional scans, CT scans, MRI scans, CT angiograms, and we're able to turn them into three-dimensional objects that we can interact with in VR. And this technology has been available to us for almost a decade now with surgical theater system. And it is very, very useful for patient engagement, for surgical planning, specifically for our use. We can interact with the pathology from the CT scans and MRIs, and we can drill, we can try to remove the tumor, we can test out a lot of approaches and so on. And that's how we mainly use the VR. So this is immersive. We can get into the skull, we can remove the brain, we can look at the tumor, which is in green here, and all the normal structures surrounding it that we need to preserve, and we figure out how to get there and how to take this out safely without damaging the patient or any of the critical structures. AR, of course, is the cousin technology that, again, I don't have to explain to this particular audience. It takes whatever we segment in VR, what we kind of create in VR as a model, as a template, whatnot, and put it into the surgical field in a anatomically accurate position on the patient and inject it via the microscope. And so this is how I have to explain AR to most audiences. And this has changed really how we practice skull-based neurosurgery. Again, skull-based neurosurgery is the surgery that we do at the floor of the skull where the brain sits. A lot of the structures there don't move, so it lends itself very nicely to VR planning and augmented reality execution. So here's old school and new school. So old school, like, okay, what do we do with this scan? There's a tumor sitting at the optic chiasm, near the optic chiasm. What do we do? The old school says that, well, there's a white-haired guy in every department that says, go do this. Why? Well, because I say so. So we take a lot of the teachings from our teachers and follow it, and then we eventually maybe come to our conclusion that we do it better this way or that way, or we keep following the same teachings because we were told to do so. The new school is no longer like that. And what we can do, even at a very young training level, is that we can examine the pathological anatomy in 3 dimensions in VR, just by diving into the skull and taking a look at the anatomy. And then we can do our own drillings in the bony structures and inspect the exposures from one and compare the other exposure to another exposure to another exposure. You can drill until the cows come home and reset and re-drill and reset and re-drill. And in so doing, you can trial various approaches to arrive at your favorite exposure. So something like this tumor, I hope you all can see my pointer. You can test out approach number 1, approach number 2. You can do all kinds of creative approaches, if you will, and without harming the patient one iota, and just by resetting the system, you can look at the exposure and come to your own conclusion as to which approach is the best for this case. And we do this quite routinely. Not to mention that we show it to the patient and say, okay, here's the pathology we're dealing with. This is why you need surgery. And by the way, this is how we're going to get there. This, that, and the other thing for all these sort of reasons. So they get involved in this. They get engaged and say, okay, that makes total sense. Now I understand what not only what the pathology looks like, but also how to get there. Old school of doing surgery, executing the surgery. Okay, we are looking at the floor of the middle fossa here. This is the temporal lobe where my pointer is sitting. How do we find the certain structures at the base of the skull? Well, again, the white hair guy in the department, this tells you, oh, you have to make a line here at the semicircular, superior semicircular canal. You have to make a line here with the greater supravertebral petrosal nerve. And then you have to mentally project a protractor into the field. And by bisecting the angles, you will then find the IAC. The IAC is the internal acoustic canal. I don't know about you all, but I don't have a mental protractor that I can just bring into the operative field and bisect angles. So the new way of doing this sort of stuff is through augmented reality. This is projected through a navigation tract microscope. And by the way, the patient's head is pinned and immobile, so that lends itself very well to this sort of stuff. So again, the augmented reality projects the anatomy of interest with guide markers and trajectories and templated bone openings onto the field, and you can turn off and turn on all these objects to guide you to the promised land without damaging stuff. So this is the new school now. How do I get to the IAC? Well, you project all this stuff onto the field, and you can see immediately how to get there without damaging all these vital structures. So the workflow then is you render the VR models from the CTAs and MRIs and so on and so forth, which takes not a lot of time. And then you put in all the critical structures that you want, put in the tumor that you want, and then you start testing out and picking approaches so you don't damage the patient and get there with the best exposure. And then you put all the markers to then guide you to the target and away from anti-targets. And then you project all this in AR at the surgery to guide you to the surgery. Three things have to interact with each other, obviously. The VR machine and the AR machine is one system that needs to interact with the microscope. The other thing that needs to interact with the microscope, obviously, is the navigation. So you're navigating the operation through the microscope, and the AR projected through that navigation tracked microscope. And by the way, navigation, of course, existed long time ago and still is in use. But that navigation is screen and pointer based. So you have to put the pointer on the area that you're interested in, then look at a screen that you have to turn your head to look at, and then go back to the operative field. So this particular system with these three interactive components take away all that pointer monitor-based navigation, in effect giving you Superman type X-ray vision to see all these things without having to turn your head and take your attention away from the operative field to do all this navigating. And plus, you can put in the markers and all that so you know what to avoid and what to go for. Again, for a lay audience, I would explain that this is basically driving like GPS. So the map is uploaded into the car, and the directions are then projected onto the screen, onto the windshield, and then stop here, turn left, turn right. And that's essentially how we're using all this to do brain surgery. So give you an example of a case that we planned with VR and then use AR for guidance. Here is a woman with a tumor that is in the ventricle. Yeah, this is the tumor here, and the pointer can point to it. It is not a very conventional place to have a tumor. Therefore, there are no standard anatomical trajectories that guide you to that particular spot. So this is where our system becomes extremely powerful. So here you are. Here's the VR model that we're diving into. We're drilling a hole in the skull and then navigating to the ventricular system. This is the ventricular system where the tumor is in green. And then what I'm trying to do here is to link the tumor to my bone opening with the trajectory. Here we are doing that. And then I know that if I just follow that trajectory down by putting the starting sphere and the ending sphere in line with each other, I will undoubtedly get to the area of interest without damaging any surrounding structures and through a very small opening. So you will keep hearing minimally invasive, or keyhole from me. And this is what a keyhole operation looks like. It's just operating through a very tiny opening so that we damage as little as we can possibly do. So very small opening. I know that I'm on target because the two trajectory markers are in line with each other. And then lo and behold, bang, here we are, take out the tumor. We go home, patient goes home, and everybody lives happily ever after. So again, minimizing the footprint of our entry by using this technology to the best way possible without looking at monitors and screens and all that head turn and all that kind of stuff. So here's the study that was alluded to earlier. We called it the century, which is because of 100 cases. The first 100 cases that we did this sort of paradigm, VR planning, augmented reality guidance. Well, how successful were we in doing this using this system? So here, this is I don't know why that happened. So I'm not going to belabor the point of the inclusion-exclusion criteria. Suffice it to say that this was an intention to treat criteria, so everybody that we intended to use this and we plan to use this, we're put into this, and then we kind of glean from that data how many we were successful in using the system to complete this, and how we used it, what was the most powerful way of using it, what was not so hot, what was problematic, et cetera, et cetera, et cetera. I'm not going to go through this in a boring way to, put you all to sleep. Here are again, I apologize for the slides. Here are the 100 cases and the distributions, a lot of meningiomas, aneurysms, gliomas, arteriovenous malformations, et cetera, not exactly out of the ordinary of the usual case mix that we see as a cranial practice. And the curve, I'm sorry, I don't know why this is doing this. So this is the curve. This is the learning curve from those 100 cases that are intended to treat. Every time the system failed to be used for whatever reason, we dropped a notch from 100%, and then we were successful for the next set of cases, and then we screwed up again, and then we so on and so forth. Now, the screw-ups are very interesting to note. A lot of times it has to do with screw-ups with the navigation system, so has absolutely nothing to do with the mixed reality system or the mixed reality computer. Somehow, some way, the navigation system failed to communicate with the microscope, and we are no-go for that case. So I believe there are about 8 of these mixed in here, and a large chunk of them had to do with just the navigation, not talking to the microscope. There are other times where the registration with the navigation was again problematic because of the patient's anatomy or the scan wasn't done properly, and then we also counted those cases. So of the 8 cases that we failed to complete, only a minority really has to do with the VR system or the mixed reality system not functioning properly. It really has, but again, because it needs 3 components to talk to each other, any one of those can fail and cause a failure. So the curve looks like that, and you can see that the inflection point is around 63, that we really started getting used to this entire workflow, and we're smooth sailing. Not to say that we didn't have any cases that failed, but the drop in this curve was no longer applicable because they were measured as percentages success completions. These slides are going to jump again, and I apologize again, having go back. I don't know why this is doing this. This shows you the 100 cases that were successfully completed. They were minus the ASO 92 cases, and how this system was really most useful in those cases and how often. So reducing the size of the opening, which is minimizing the footprint of neurosurgery, really was 44 out of those 92 successful cases. The vast majority of cases, we were able to place the opening very, very precisely because of this system, and only because of this system. The guidance to target is self-explanatory. It's very intuitive that this guides you to targets. And a lot of times it guides you away from anti-targets, these critical things that you want to just stay away from. This is not an easy concept to grasp, insofar as the pointer monitor system can often fail to find these things because they're hidden by bone, because they're hidden by soft tissue structures. And again, with the X-ray vision afforded us by the VR/AR guidance, this is a concept that is new and fresh in neurosurgery, not previously accomplished by the pointer monitor system. And there were, in fact, 14 cases in the 92 that we successfully completed that was critically dependent on mixed reality guidance, and I will show you some of those things as we go along. This is again going to jump, and I apologize once again. All right, let's just not belabor the point and jump to the concept of minimally invasive surgery and how this all changed the game for us with this guidance system. This is a case that I did over 20 years ago. And it is, okay, in meningioma stuck to the skull base. And back then when I was in, just out of training, the concept is take out huge pieces of bone, just large openings, large openings, large openings, with the idea that with large openings, you have to damage the brain least. With large openings, obviously, intuitively tells you that it produces a lot of distress in the patient, right? There's a lot of approach associated trauma and pain. So this is now current. Same tumor, maybe even bigger, and the opening is much, much smaller. We call it a keyhole, and this is a 2.5 by 2.5, basically 1 inch by 1 inch opening, if you will, as opposed to this giant opening that we did 20 years ago for the same sort of tumor. So a lot of this talk now is about how this mixed reality system allows us this transition. So keyhole is great if you think of it as a patient preserving measure. You damage less, patient go home earlier. Conceptually is very simple to understand. And we all want keyholes that look like this. You peep into it, you got a beautiful thing behind it. In fact, a genius creation in Brunelleschi's dome behind it. But if you don't place the keyhole properly, if it's too small, if it's out of position, what you have is this, which is a train wreck. So we don't want those. So how do we accomplish all that by mixed reality? This is something I call the Goldilocks principle, which is simply that it has to be just right. It cannot be too big. Obviously, they're not keyholes anymore. Can't be too small because that's dangerous. Can't be too anterior, posterior. It has to be, everything has to be just right, just like Goldilocks likes it. So the transition, again, by mixed reality. Here's an example. A very deeply located tumor in the, what we call the, well, it's a posterior clinoid meningioma. And this is a very challenging area to get to, no matter who you are or what system you use. What we do is create a connect the dot sort of system with VR. We created this model. Go slower here. And pause. We created this model where the tumor is embedded in the normal brain, and then we simply created this dot system where we simply had to go from dot, which is the first dot is the sulcus, then the second dot is the temporal horn, third dot is the tumor, and then we go dot to dot to dot. So this is, again, driving with that GPS projected onto the windshield. Take a left turn here, take a right turn here, take a left turn here, and you get to where you need to go. Here is the AR now. What you're looking at is an anesthetized patient. The brain is exposed and locked in pins, anatomically locked in. And this is the AR projected through a navigation tract microscope. And this edge that you see here is the bony opening that we had templated with our VR system. And this is projected onto the patient. We know exactly where to go first. Just go here, dummy, sort of a marker to show you where the first incision has to be in the sulcus. And then you get to the temporal horn, and then you follow the next dot into, okay, there is temporal horn, and then you follow the next dot, make the right turn, and you get to the tumor, which is shown right. Well, not yet. Right next to my yellow dot there, these are normal structures, and we just have to make a little right turn, correct it, and then there it is, the tumor. So driving with GPS, we get there through a very deep opening, but a very small opening. We start taking the tumor out with a cavitron. This is the end view, and there's the end result. So that is one way of using this system. Another way is using new and not so familiar approaches, such as a transorbital approach to get to tumors. No one has done 5,000 of these. No one has done enough to kind of get there blindfolded. So again, this guidance system becomes extremely useful because we can do all this templating in the office and in the lab, and then bring the template into the operating room as augmented reality guidance. So this is a tumor just behind the orbit in the temporal fossa, and we had all the guideposts needed and all the markers needed to do this with AR. What you see here now is, again, the locked-in patient and AR projected onto the field, and that purple line is the lateral extreme of the tumor as seen through the orbit. So I know that as I start drilling at the purple line, I'm just getting to the lateral edge of the target. As I move more medially, I am more and more exposed now, and then I can open the dura and get to the tumor without too much strife. There's the drilling on the purple line, and then we get more and more medial. We just follow that green mesh. That's the anterior clinoid marker. I know I'm at the anterior clinoid basically there. Start opening some of the dural structures, drill out the anterior clinoid, and the fact that we will get to the tumor is never in doubt. So very, very useful and very powerful. More examples of taking out large tumors, what used to be through large openings, now through tiny, tiny openings. Again, that transition is afforded by our guidance system. Yet another example of a very deep tumor that we can just do a very tiny opening for, again, with this sort of guidance system. And here is an interesting case that we need to talk about a little bit later. This is a post-op scan. Here's the pre-op scan. You will recognize that this tumor is near the speech area, near Broca's area in the dominant hemisphere. In this day and age, most people would do this awake, talking to the patient during surgery, so you can map the language areas and whatnot. This particular patient was not a candidate for awake surgery because of her age and her personality and so on and so forth. And we were not able to do her awake, and therefore, whatever we do would put this patient's speech function at risk. Well, we did the best we can with augmented reality, mixed reality. What we did was we did a PET scan to show us the speech areas. We projected the speech areas in augmented reality onto the patient's cortex, and we simply stayed as far away from the purple as we can, stay as far in the green as we can to take out this tumor as thoroughly as we could without damaging her speech function. And you can see that this is the end result. We had a near total or intended partial resection, and we were able to leave all the middle cerebral artery structures in place, and she woke up talking, thank goodness. Here's another example of a giant tumor taking out through a tiny opening as afforded by us by that mixed reality system. Again, we did this planning. We cut here, and cut here, and well, the tumor can come out through very small openings. Can we really do this? How do we know that we can do this? Well, all you need to do is really test it out in mixed reality, and we were able to show ourselves that this was doable. So we ended up doing 2 small openings, one in front, one behind, one right, one left, and we're able to take out this giant tumor through only these small openings. And I wish I had the model to show you, but I don't seem to have that slide. All right, I messed up there. So minimally invasive cranial surgery, very, very much put forth by this mixed reality system. We change gears now and talk a little bit about vascular surgery and how this can be helpful. How about aneurysms? This is an aneurysm in the middle cerebral artery, and we would have, let me stop it right there. So here's an MCA aneurysm right there. The pointer is pointing that to you. Without the system, I would never dare to operate on this through such a small opening. The traditional opening is about 5 times as big as this, so that you know that you have enough angles, you have enough opening. If disaster strikes, you have enough freedom to manipulate out of it. But again, we practice this approach in VR in our own office, drill and drill, and look at the anatomy in such a thorough way in 3D that we convince ourselves that we can do this with very small openings. And here we go, executing it with a templated opening projected in AR. And lo and behold, here it is. You can see the template projected on the patient. We're marking the template onto the patient's skin. Patient's anesthetized, locked into the pins. And we do the opening exactly as we had planned it. And then lo and behold, boom, it guides us right to the aneurysm with just the right trajectory, plenty of room to maneuver. And then we put the clip on that thing and it's over. And the good news for these sort of patients is that because of the small opening, they go home a lot earlier, and we have solid data now that says that that in fact is the case. I'll show you at the end of this talk. It's really powerful when there are unusual trajectories. So here's two aneurysms on two different sides of this patient, but we access this through one approach, one minimally invasive approach. And this is not something that we do every day because we don't operate on opposite side aneurysms through the same openings every day. But because we have practiced it in the VR lab, we are able to do this without, again, a lot of ifs, ands, or buts, because we've seen this in the office. So here it is, the first one getting dealt with. This is a very conventional approach. It's the reach over to the next one that is unconventional and very much aided by the system. So you can see dot 3 is where I need to go. I'm looking from the contralateral hemisphere, and this is a very odd sort of approach that you say, well, you know, are you sure the navigation is still on? Well, every time I try to question that, I end up being wrong, and the navigation is still right on, and boom, it guides us to the aneurysm, even though the trajectory is odd, and we were able to successfully do that through a relatively small opening still. Here's the end result, aneurysm there, aneurysm gone, aneurysm there, aneurysm gone. Now, here is a case of a basilar apex aneurysm, subarachnoid hemorrhage ruptured case that is very unusual to do open these days. Most of the time it's endovascularly treated, but this particular case, because of the shape of the aneurysm, endovascular treatment is not good. And so we did this, again, very rare operative case these days with all this guidance system. The first P is where I need to drill the posterior clinoid process, not something we do every day. Again, the rarer the element of approach, the more useful the system becomes. Here we are drilling away. And then I need to get to the basilar trunk. Now, where is the basilar trunk? Well, the basilar trunk is invisible here, but I got X-ray vision here. I know that the basilar trunk is here because I segmented it and projected an AR there. I know I need to get there to get to the basilar trunk. I hope you all can see my pointer, by the way. And because of the cake blood here, no one can see the basilar trunk but the AR system. So let's get rid of the clot because I need to go that way. And there it is, a basilar trunk. I put a clip on it to get proximal control. And then we take care of the aneurysm. Not a lot of fanfare after that. So again, helps us with procedures that we don't do every day. And again, the practice is not only through experience and years in practice and so on and so forth, but through VR guidance. There it is, the end result, aneurysm gone. And all right, so here's yet another very unusual case that to show you. I hope you're all following all this with at least it's interesting to you. I hope so. Here's an ACOM aneurysm, okay? Nothing unusual about that. It's being fed from the left side, only from the left side. Well, the problem is that the patient's left side has a skin graft that I can't go through. So the old-fashioned way of going through to this aneurysm is not to be had because I cannot touch that skin graft. Well, let's do something unusual then. We decided to go transorbital with this. I had showed you previously a transorbital tumor case, but here we are doing transorbital for a vascular case. And so because the forehead was no touch, we thought, hey, we actually use that orbital approach through the conventional approach anyway, that trajectory. So why not just do the orbit? So the craniotomy, so to speak, is really at the floor, the orbit roof. Here's the orbital rim coming off, just that tiny little bit. And we drill and we drill and drill, all orbital work. The globe is getting retracted down. And we're taking the orbital roof, taking the orbit, finding the optic nerve. And the optic nerve takes you to A1, A1 takes you to the aneurysm. And again, this is only doable really because we had practiced it, rehearsed it in the office. No way would I do this on a patient without that sort of practice afforded us by a VR, because that would just be too cavalier and not ethical. This I feel perfectly fine doing because I know exactly what to predict. And sure enough, that aneurysm was nicely eliminated without touching the forehead whatsoever, only through a transpalpebral and transorbital approach. We have now done this several other times for other people. Nowhere in vascular surgery is this system more powerful than in AVMs. And I will tell you why in 1 second. The reason is that AVMs is extremely complex for neurosurgeons because of the angio architecture. Where is it coming in? Where is it going out? Imagine trying to disentangle a bomb or cutting the wires in a bomb, except those wires are all in one giant tangle, and you have to cut the green one and the blue one without disturbing the red one and the yellow one. And that's the hard part of AVM surgery for neurosurgeons. But remember how we used to learn the brachial plexus? We had to color each root, and then suddenly this becomes intelligible. Well, now we can do this same thing with AVMs to disentangle the angioarchitecture in our brains. So here's a very complex AVM that's been embolized several times already. Here it is. We can't make heads or tails out of it. But if we put the scans all together and then we start doing what we did to the brachial plexus, which is we now colorize or segment each of the feeding vessels, one in green, one in yellow, one in purple. Okay, here's one, and then here's another one. And then we put the marker where we need to disentangle, where we need to disconnect these spots. So those are markers that I call cut here dummy markers. I don't need to question about which wire I need to cut first. This engages bomb. I can simply just follow the markers 1, 2, and 3 and cut here dummy. And so in real life, we project all these markers and trajectories onto the patient with AR and simply follow the plan. It has made speed it has sped up the operation tremendously and has also made it safer. So we're going transfalcine for this very first cut because how deep that feeder is. And imagine going transfalcine from the other hemisphere to get to this feeder. It's nearly impossible if you don't have firm and accurate guidance. There you go. We cut the falx. There's the feeder. There were no ifs, ands, or buts, head scratching, sweating bullets. Eliminate that, and the big feeder is already gone. So that took all of 20 minutes. And without this system, I bet you would have took hours and hours of trying to figure out whether this is the right wire to cut and so on. And then each one in turn taken down by this colorized system. And in AVM surgery, again, this is an absolute game changer. It makes the anterior architecture almost as simple as coloring, like a coloring book exercise for my kids. And then comes this. Here's another case of AVM. I'm going to skip that in the interest of time here. Bypass surgery, similar sort of thing. You practice all the bypass. You look at all the bypass anatomies in VR so that there's no doubt in AR. Here's the stenosis of the vertebral artery in the neck. We bypass this way up at the base of the skull using occipital artery as a conduit to hooking it into the vertebral artery, boom, like that. If you see the bridge between, this is the vertebral artery and the occipital artery just goes into it. Now, not an operation we do every day, but with guidance, it becomes very, very straightforward because of all the markers that you can just simply follow. Here it is in real life. We're digging the occipital artery out. And then we have to mobilize the vertebral artery out from between C1 and C2. That is not an easy task to do without guidance. And then once that is out of the field and pops out into the surgical field, the plugging in of the occipital artery into it becomes relatively straightforward. So the green is what you see as a vertebral artery. I know I need to dig it out of C1 here. I bring it out of the transverse foramen as a recipient. And then I believe the next slide is what shows you And here it is the actual sewing of the anastomosis. The occipital artery goes into the vertebral artery, and there goes the bypass. And the post-op scan shows that the bypass was alive. This phrase I found in a recent piece of literature. It says is a plaything the neurosurgeons charmed by the magic of high tech. Believe it or not, this was actually not about XR. This was about navigation, written in 2003, only 20 years ago. Obviously, everybody uses navigation now. It became universal. And my hope is that this will not be a plaything for neurosurgeons, but become universal very soon. Does it make me a better surgeon? I think it does. I think it makes me safer. I think it makes me able to do operations in a smaller fashion, in a minimally invasive fashion, as I showed you multiple times. And does it benefit the patient is the real key question, right? If you do something small, does it necessarily really help the patient? So we actually did this as a study, cui bono, who benefits from this? What is this for? We did retrospective analysis of the keyhole operations and compare with classic. The assumption of the minimally invasive school is that with less tissue trauma and less approach trauma, the patients go home earlier. This has been an assumption up until really, I think, our study. We did a pairwise comparison of duration surgery, blood loss, length of stay, and narcotic needs. And these are not all AR patients. These are just simply keyhole versus classic operation head-to-head comparisons. We did match studies of pathology, complexities, location, and so on and so forth, and see what came out of the wash. And what came out of the wash was actually quite stunning to us. We had 37 pairs of patients, again, matched pairs between minimally invasive and classic operations. And we showed that the duration of surgery, the length of stay, and the narcotic needs were significantly less in the minimally invasive school. So cui bono, the patient bono, the patient benefit. And we're not doing this just for our ego's sake, just because we are making assumptions that small openings are better for patients. But actually now we have proven data. And I can tell you that the transition for me from classic to minimally invasive was very much afforded by this mixed reality system. So I'm going to stop there. I'm going to ask for questions and see what you all think about this. Here are my contributors and all my fellows and all my students as well as residents. Thank you. Thank them for all the work, and I thank you for your attention. So I'm really curious about how you all think about this in the future. Thank you.
That's really excellent, Walter. Very illuminating. And I encourage the audience, please put your questions in the chat for hosts and panelists. Here's someone. How many trials does a trainee go through in AR and VR averagely before going to the patient?
That's a great question. Obviously, the real answer is as many times as they take, right? I have been using it mainly. So I would go and test out approach A, approach B, approach C, and I would convince myself that, okay, this is the best. I can easily ask the trainees to go, you do it. Tell me what you think. And then if your answer and my answer coincide, then we do the case together, things like that. The trainees' access to this is limited because of time. They don't have a lot of time to just go into the VR lab and just kind of drill and drill and drill, which is an unfortunate thing. One would hope that their rotations and their training will then, as the systems become more and more prevalent, that it will become part of their lives, and they get more time to do this, more dedicated energy to do this. The other thing I find is that a lot of trainees are not, the speed with which they get comfortable with the joysticks, with the controllers, is extremely variable. For some, it's very, very intuitive. For others, it takes a long time. So that element also is a little bit of a barrier right now for trainees using this over and over again. So we haven't done any studies about how many times the trainees have to do this and how many times they need to learn this. But that's a great idea.
Cool. What are the biggest impediments to wider adoption to Well, the question says in all forms of surgery. Perhaps you could answer it more narrowly.
It's really the money. It's purely the Benjamins. Hospital administrators, if you believe the data that's out there, the return of investment is automatic. All you need is to convince one patient that with this technology, it's safer for them. Once a patient a year, the system already pays for itself. All right, so let's say this patient was going to go to Boston for treatment, and for lack of a better city, if you compare, but we were able to convince the patient that hey, stay in Allentown. We got this covered for you. We got this very safe thing for you. One patient a year, the system already pays for itself. But because the system is expensive, I think that's really the main hindrance to this wider spread. You need a pair. You need the surgeon to be convinced that this is useful, and you need the administrator that holds the purse strings to be convinced at the same time. You need both these elements to then get the system. One of these not falling in line, either the surgeon saying, it's just too cumbersome to learn. I'm not going to learn this. I'm an old dog. Don't teach me new tricks. You're done. And then same thing with the money aspect of it. So there is an obstacle for sure in that regard.
Here's a question. Can you talk more about the technology you use? I could make that question more specific if you like.
Well, for me, it's a commercial product. So I'm not an engineer. I can't tell you the guts of this system. So again, the system has been available for the last 7 years or so, more than that. And if anybody's interested, I can talk about the company later offline. They have been very receptive to the ideas from our side, though. We say, for example, that painting system of AVMs. I said, why don't you have a 3D painting system? It would really decode the entire AVM for me. They immediately gave it to me. They said, okay, don't spread it. We're not selling this. This is not a so-called approved. But if you want it, here it is, and then we'll get approval later, right? And it was game changing for AVMs. The guts of the system, I really can't tell you.
Okay. I'm skipping around a little on this list of questions. In assembling the technology, the scans, the CT scans and so forth, when you're creating the models for the planning session, how much assistance do you have from an engineer's or a
massive
lot? Okay.
The system is not intuitive, and I've been using it for 6 years now. I don't have all the nuance, buttons and bells and whistles all under my command. So there is a dedicated engineer that's married to the system, if you will, that's doing all this work for us.
So it's not I'm actually familiar with surgical theater. It's a semi-automated system.
Yep. That's the best way of describing it.
Excellent. Are you doing anything with VR and eye tracking for training?
Not yet.
Okay.
That's a interesting idea that I haven't really thought about yet.
Okay. Someone asked, would you be interested in information on company providing the system you use? I think he wants to know what system you're using. Is that right, Franklin? I mean, it's surgical theater.
Yeah, plain and simple. That's the answer.
Yeah, there you go. Let's see. Did you compare surgical theater with other systems like MediVis?
The simple answer there is no. I fell into this, right? I was not the person pushing the acquisition of this in my former job. Um, it was made available to me. I started playing with it, fell in with it, started thinking about ways of using it, and it just kind of it was coupled the way that my brain seems to function and the way that their engineers and all seem to work very well together. So we kind of had a synergy going, and I came up with the ideas, and they adopted it and gave it to me, and then back and forth, back and forth. Other systems, I've kind of seen them at conferences and shows. What do you call those sort of those vending shows, conventions.
Right.
But I'm so comfortable with this system now. Um, I haven't ventured for too far.
Very good. I have a question. Is the surgeon who's doing the surgery the same surgeon who did the surgical planning?
Oh,
So
I think it has to be.
has,
I think
okay,
it has to be. Otherwise, you'd be lost. If someone did my planning for me and did my templating and did my trajectory laying and marker laying, I'd be like, what is this? Who? What is this? See, it's idiosyncratic, right? I want marker one to be here, I want marker to be here to here. I know exactly where marker one and two are, so you can just go and not have to like scratch your head on that.
excellent. So when you're following those markers, you're following them intelligently. You know the context, you know the tolerances, right?
Exactly, and I'll tell you why. Because I tell you how that it was so impactful. The z-axis is something that still needs to be uh, fine-tuned, right? You see a three-dimensional object, you can easily get confused as to which side of this object is deep to you versus superficial to you. That's what I mean by the z-axis. If you didn't put that marker in or that segmentation in yourself, how that object is laid out in AR, whether it's this way versus that way, which way is the z-axis going, it becomes immediately confounding.
Interesting.
Um, so sometimes we even have to, if it's a blood vessel, we may even have to segment it by purple, less dark, more red, then pink, that to understand that the blood flow is in a certain direction. Otherwise, you just see the three-dimensional steak and you don't know which way the head, which way is the tail.
Right.
So we have to do your own segmentations.
That's very, very useful, very interesting. I know you have good depth perception in the VR system. I've used it. How's your depth? Is the z-axis you're talking about, is that depth perception?
Yeah, depth perception
Yeah,
in AR, and that is something that you have to be extremely careful with.
right.
As I already said, the other way of going around the z-axis topic is really laying down the trajectories. So you know that, okay, if you need to go in a certain direction, then you put in the trajectory and you have the starting marker and the ending marker in different colors, let's say. And then you say, okay, now I've superimposed those two markers. Now I know I'm going this way. I know I'm going in the right direction. That's one way of kind of getting around that z-axis issue.
Interesting. Can you control the opacity of the markers? Can you
Yes,
turn them up and
yes. That's the other reason why that engineer has to be in the OR with you.
good.
If you're using foot pedals and mouse switches on it, forget it. It's too complicated. You just say, hey, I need lighter, I need darker, I need off, I need on, I need off, I need on, that way you can say, bring in this one, bring in two, bring in one, bring in four, darker, lighter. We have this interaction dynamically.
Excellent. Another question from the audience. What do you see as the possible dangers of this technology?
Well, that you're off. If you're off, if the navigation is off, if something is off, then you need to be aware that it's off. You don't just charge in there. Um, but as I alluded to in my talk, they're usually more on than it is off. It's more often for us to think it's off when actually it's on. It's right
Right.
on, and that way. The other thing is this concept of this plaything again, right? That you can get dependent on it. You're going to get spoiled by it. You're going to say, "Oh, I can't operate without it." I hope that never happens.
Mm.
Uh, navigation is getting to a point where if your navigation is down, you like, I can't do it. The old school neurosurgeons are the one that was what they were warning against. That, now you have an operation that you can't do without this. But if it's safe, there's a give and take between, whether it's dependent on technology versus safety concerns. Theoretically, there's a gray area there. Hopefully, we don't get dependent on it.
Very good. Here's a two-part question. Are there IT requirements to use the system in the OR?
Yes.
Okay.
Well, it's all about hacking in and using this as a conduit for viruses, and
Right.
they're very, very protective against all that.
Right. Is there any intelligence built into the system?
Yes.
Interesting.
Yes, but not in the realm that I deal in at
Okay.
this current time. And this is going to sound like a commercial, but here it is. This system is now available for spine. Okay, so you can do the same sort of planning and drilling and whatnot in spine. Now you put in the hardware and you correct the deformity. It's now the computer that tells you, okay, you've got 3 screws here, 4 screws over there. You bend it this way, how much force? Now your deformity is corrected by this much. That's the AI.
Mm.
No, I'm not a spine surgeon, so I don't use that, but that's available. And, at some point, maybe it will translate to cranial surgery. What I can see in terms of intelligence happening soon would be something like an aneurysm clip. You say, okay, this particular approach, this sort of trajectory, that exposure of the aneurysm, you're going to need a clip that has this length and that bend and that angle. Okay, I don't have it. Well, 3D print it. Okay,
Mm.
boom, now you have a bespoke aneurysm clip for that case, for that exposure. It's coming.
That's great. Let's see. I'll take the last, or sorry, ask the last question. Besides yourself, who else on the surgical team needs to know the surgical plan? And does the VR, or for that matter, the AR, help in the shared understanding of what?
Absolutely, positively. The VR plan allows me to communicate the whole plan to my trainees and my helpers. So
Yes.
whoever needs to be putting their hands in the case. There's nothing better than to using that to explain, here's my idea for the, what we're doing today.
Yeah.
So the residents, trainees, fellows, etc. Plain and simple.
That's very interesting. I had an architect said pretty much the same thing about communicating designs between expert architects. Thank you for your short, specific, complete answers to all these questions. You're probably the best interview guest I've ever had. We covered a lot of ground. Thank you. I'll let you take over, Steve.
Yeah, thank you, Jeffrey. Dr. Jean, I want to thank you. This is a really important segment of the application of XR in surgical instances, and it's because I think the field of cranial and neurosurgery has had the radiological support, the engineering support for a long time, and the patient is immobilized so that we can more easily register the augmented reality navigation, which I know many different locations, MxR in particular at the University of Maryland, is working on markerless registration. But it's still a developing field, and will expand a great deal. That many more types of surgeries will be done with the safety and confidence that cranial surgeons have developed in their equipment. So this is a very, very important talk, and I thank you very much for it. Jeffrey, thank you very much, Dr. Jacobson, for moderating. It's always good to have someone who has domain experience to be at the helm. And I thank our audience today. Look forward to seeing you all again very, very soon. And double thank you, Dr. Jean. This will be online in about a week. So if you want to come back and study more carefully, come to our website.
Thank you.
Thank you. Take care.